This is a brief overview of addictive disorders, and really it's going to be kind of a conceptual um, presentation. We're not going to be diving too deeply into any particular addictive disorder, but it's going to be discussing primarily the definition of addiction kind of writ whole. Going to talk some about clinical phenomenology. We'll talk about the neurobiology of the motivation and reward system upon which the pathophysiology of addictive disorders is built. We'll talk about etiologies, go on to a little impact on health and society, identification and treatments. This is actually a variation of a presentation, a lecture that I give to medical students who are doing their psychiatry rotation at California North State University. So it'll be going back to school a little bit for some of you. But I think it's good to just kind of set a conceptual framework as we begin to talk a little bit more about opioid use disorders in particular, and in Suboxone treatment. Okay, so definition. Addiction is, and this is probably the best one that I've seen, that encompasses most of the main features. Addiction is a chronic, relapsing, usually progressive neurobehavioral condition characterized by a dysfunction of the motivation and reward neural network. So the first thing to point out in this definition is that it's chronic. So it's best managed through kind of a chronic condition framework, like diabetes or some other chronic disease. Kind of realizing that it's never really gone, and it needs to be managed really continuously in order to keep it from progressing to a more serious disorder. It's also important to remember that it is, in a lot of cases, probably most cases, progressive. So it can start out mild and given enough time, usually progresses. Not always, but frequently. And then again, it's really very much a lot of the etiology is hardwired in the brain. So we're not going to go over in detail the DSM-5 diagnosis. There's 11 symptoms that are in the DSM-5 for substance use disorders, and it's important to realize that they're the same for all disorders. So regardless of the substance, they're all diagnosed using the same framework. I do kind of like, and I don't know if given 10 minutes, whether I could remember all 11. It'd probably take me a while. But I do try to remember them in terms of functional categories. And most of the symptoms, actually all of the symptoms, fall into these really what I consider functional categories. Craving and loss of control, so the beginning of the compulsive behavior, use in hazardous situations, or risky use. So drinking and driving would certainly be an example of a hazardous use pattern. Impairment of social function, and a lot of times that occurs, kind of later on in the condition. A person will start having problems with family and maybe with their employment. And then tolerance and withdrawal, and depending on the substance, that can happen quickly or can take a little bit longer to occur. But I just kind of put it as the mnemonic chit. I I was in the military, and we back in the day we used to use the word chit for like a memo. So I don't know, maybe that's just meaningful to me, but I felt compelled to make a mnemonic out of it. So there are severity differences between addictive substances. Some substances are much worse to be addicted to than others, and they differ in terms of their mortality rate. A lot of their morbidities that occur. Of course, you guys are all familiar with a lot of the physical sequelae of alcohol use disorder, and then the degree of social dysfunction that occurs to them. Just an example of the mortality rate. This is years of potential life lost, and as you can see, heroin use is pretty much the grandpappy of all substances in terms of its effect on mortality. If you kind of flip this around and consider that in the U.S. the average life expectancy is about 80 years, you can see that for heroin you subtract 44 years of life lost, and you have an average life expectancy of 36, which is cutting someone's life more than half. And then of course other substances are serious as well, but because of the mortality rate with opioids, I mean that's part of the reason that it's such a important public health issue at this point. And then within disorders, there are differences. All substance use disorders come in small, medium, and large. It's really on a spectrum. And this one is for alcohol. That's probably the best studied of all of the substances. But as you can see, you go from basically very light drinking, with no consequences, to lower risk drinking and medium and on up, and you've got the consequences on the other side that frequently accompany those pyramids. And sometimes people will, their disorder will not necessarily always go in order. They'll have some difficulties on the right at a lower stage, but in general, this is kind of what happens. And again, a lot of folks, it's very progressive. Oh, sorry. Okay, so a little bit of talking about the little bit on the motivation and reward circuit, sometimes considered the pleasure circuit in the brain. First of all, the motivation and reward circuit, it's highly preserved across vertebrate species. As you can see, that little mouse is very fond of Oreos, and really all vertebrates have a motivation and reward system in their brain, and part of the reason for that is that it really it's an important system, and it provides evolutionary advantage for species as they're trying to compete for resources and mates and avoiding pain as well. That's pain avoidance has been shown recently to actually be a source of reinforcement by the reward system. Right. Okay, so a little bit on the neurobiology of the pleasure circuit. I think most of you guys have heard of, the role of dopamine in the addictive in addictions, and that's certainly the case. But it's a little bit more complicated than that. In the last probably 10 years, the neuroscientists have elucidated kind of another component to the pleasure circuit, and that's the hedonic circuit. And this is probably my drug of choice, ice cream. And as you can see, there's kind of the like it, love it, gotta have it kind of represents the process in the brain that occurs. You have recognition of a stimulus. It's noted as being pleasurable in the hedonic circuit. It then is that signal is then transmitted to the reward circuit, including the nucleus accumbens, and I'll have some slides on that the next couple. And then so there's a recognition, there's kind of a signal amplification with the reward circuit, and then there's the signal then gets transmitted to the higher cortical centers, where you start planning on how to get more. Okay, so this is just a little cartoon of hedonic hotspots in the brain, and the important, first of all, this is a rat brain, but again, back to the fact that this network is highly preserved. It's in all mammals, but part of this is just to kind of diagnose or demonstrate that the hedonic circuits are really distributed kind of throughout the subcortical and cortical areas of the brain. And so it's fairly complex way to that our brain has in kind of recognizing the pleasurable signals. Nucleus accumbens, that's kind of where a lot of the dopamine release and signal transmission occurs. There's dopaminergic neurons in the ventral tegmental area, the VTA there, and they have projections to the nucleus accumbens, which is sometimes referred to as the medial forebrain bundle, and is also kind of spoken of in the literature, at least a lot of the earlier literature before we knew about the hedonic circuits, as the pleasure center of the brain. And then the anterior cingulate and frontal cortex, that is those are the higher cortical areas in the brain where you start doing planning for obtaining more of the pleasurable stimulus. So kind of moving on to etiologies, the addiction generally follows a biopsychosocial paradigm, like most other behavioral disorders. In terms of the genetics, and the one that we're most familiar with is alcohol. There was a recent meta-analysis of twin and adoption studies. They've been doing those for years, dozens of years, as a matter of fact, probably 40 years. And they recently analyzed, I don't know, maybe 100 or more of those studies, and basically found that, kind of averaging out the studies, it shows a genetic influence of alcohol use disorder of about 50%. And kind of, the particular mechanism of that genetic transmission is that you have polymorphisms or forms genes that code for different enzymes and structures that are basically forms that are um, not as robust, or they either work not as well as the usual structure, or in some cases they work a little bit more, which also can sometimes cause problems. So they've found polymorphisms in genes encoding for alcohol dehydrogenase, aldehyde dehydrogenase, the opioid receptor, and as some of you know, the opiate system is an intermediate agent in some substances, and the addiction part of it in the nucleus accumbens and other structures. Dopamine receptor, GABA receptor, corticotropin releasing hormone receptor, brain-derived neurotrophic factor, and then other proteins which are implicated in toxic stress damage. So this is just a little thing on alcohol metabolism and kind of an example of differences in the polymorphisms and what effect that has. So alcohol, this is the metabolic pathway of alcohol. Alcohol is metabolized to acetaldehyde, which in turn is metabolized to acetic acid, basically vinegar. And there are certain ethnic populations that have a aldehyde dehydrogenase polymorphism, which is protective, and basically in that case, the enzyme doesn't work as well. So what that does is that builds up acetaldehyde in the blood, which is basically a toxic substance and causes flushing and some other uncomfortable symptoms. So it's kind of a natural aversion, kind of a built-in aversive system for alcohol metabolism in some folks with Asian ethnicity. There's other populations in which you can have different polymorphisms, which either make one more susceptible to drinking in excess, or less susceptible relative to the wild type, which is the unchanged genetic sequence. So that's genetics. Some on the environmental effects of or environmental factors in the development of substance abuse disorders. I think most of you guys have heard of the adverse childhood experiences studies that have shown that folks with adverse childhood experiences, such as being the victim of abuse, being separated from a parent, witnessing violence. There's in the official study, there's 10 adverse childhood experiences that are generally looked at, but they've kind of in general, they've found that the more the adverse childhood experiences, the more negative outcomes for folks. And that certainly holds true in particular for alcohol use disorder and IV drug use. Then that's mostly heroin. And as you can, the odds ratio basically is a measure of kind of how much more likely compared to average is something. So if a person has 4 or more adverse childhood experiences, they're about 11 times more likely to have a alcohol use disorder, and these are defined in the study as being, you know, significant alcohol use disorders. So, so another reason that folks developed substance use disorder, sort of related to adverse childhood experiences, is that they're self-medicating. They're self-medicating very uncomfortable emotional, negative emotional states. You know, you can sometimes conceptualize them as psychiatric conditions. There's, you know, as you guys know, there is a huge co-occurrence of mental health and substance use disorders. And, you know, in some studies, it's in ambulatory populations, it's like 30–40%. In more institutionalized settings, like a residential treatment center, it's more like 80%. So kind of depends on the population that you're looking at. So one of the things that researchers have done is they've looked at the sequence of the development of mental health conditions versus substance use disorders, and they've found that in some conditions, the onset of the psychiatric condition predates the onset of the social use disorders. Substance use disorders, and that's particularly true in anxiety conditions or conditions that have a lot of accompanying anxiety. In depression, it's been found to be bidirectional. So sometimes, about half the time, the depression comes first, and then the alcohol or substance abuse problem occurs, and sometimes it's just the reverse, where you have the substance use disorder condition occur first, and then a person will subsequently become depressed. Now, that doesn't necessarily mean that one caused the other. It could mean that there's a common substrate to both conditions, and so they were both going to occur anyway, but just kind of at different times. So pathophysiology, this is kind of going back to the motivation and reward network. This is a very busy slide, and I'm not going to really go over it in any detail, but this is mostly to show some of the structures of the motivation and reward system, and some of the pathophysiology that occurs in SUDs. So one of the things that does occur that we see clinically is a hedonic tone reset. It used to be believed that people with addictive disorders were hyperhedonic, or were they just they were too focused on pleasure. They were kind of basically they were hedonists. They were people who just, you know, that was their thing. Pleasure seeking was just huge in them, and so that sort of led to some of the kind of the moral theories on addiction, that it's a weakness of character and so forth. But what they've actually found is that most individuals with an addiction actually have a lower baseline hedonic tone. So, and that's just another way of saying they have a hard time enjoying kind of regular stuff, stuff that's you know, that most of us get some mild pleasure or gratification from. And so, kind of going somewhat linked to the self-medication hypothesis that folks are just trying to make themselves feel a little more normal. And not only do they start with a lower hedonic tone, but it also gets worse as folks progress in their addiction. So, one of the things that folks find when they take a substance, kind of acutely in the beginning of their disorder is they feel good. It gives them a boost of euphoria, and that of course reinforces it. But as tolerance develops, there's more and more necessary to get the same effect. And what that actually does is that reduces their hedonic midpoint. So their ability to enjoy things just sinks lower and lower. And then, and you've heard this clinically from folks, a lot of times, folks that are in the later stages of their addiction will tell you they're not having fun anymore. They're just trying to not be miserable. So that's kind of one of the really dark parts of addictive disorders, is it just is ultimately self-defeating. Talking a little bit about some of the specific disruptions of the dopamine reward network. There's actually a couple of separate things going on here. So looking at the left-hand side of that, of the cartoon, you have the dopaminergic projections from the nucleus accumbens to the prefrontal cortex. And there's a couple of different types of receptors. There's one that mediates high-intensity rewards, and that is very fast. It's basically based on ions just flowing across a barrier, so it works very, very quickly. There's also a dopamine receptor that mediates kind of smaller intensity rewards, and that is basically based on what they call a second messenger system, where there's actually a turning on of nuclear machinery in the cell. So that takes much longer. And basically what happens when you have excess dopamine is it shuts down the low intensity reward. So basically what happens is that people have, and kind of as we saw in the last slide, people have just diminished capacity to enjoy regular things, spending time with friends, going for a walk, petting their animal. They just don't enjoy that anymore, and there's a good physiologic reason for that. That's because those receptors that are responsible for helping us to enjoy those things are just shut off. Another thing that occurs on this slide is the top. In the top of the slide, top of the cartoon, there's that blue line, and excessive dopamine stimulation, it leads to a release of corticotropin releasing hormone, and that increases the stress response. So basically that corticotropin releasing hormone leads to increased cortisol, which leads to increased stress on the brain, and there's a whole huge lecture that goes along with that in how that occurs. But just suffice it to say that increased levels of cortisol eventually make a person less resilient and more sensitive to stress. Increases dynorphin, which also increases the stress response. So moving on a little bit to impact, first societal impact. So the total, this is United States population of 330 million, 21.5 million have an addictive disorder. And so that's about 8% of the population. Of that 8% of the population, about 2/3 of that is alcohol only, or primarily alcohol. And then the other third is a combination of drugs or drugs and alcohol combined. So alcohol, far and away, is still the most common use disorder. Oh, sorry, that's a board question for for some of the med students. I meant to take that out. This is the societal impact in terms of mortality, and for all the talk that we've had on opioid deaths, and it is significant because it's it's now much higher than motor vehicle related deaths. Last year, I think there was a combined total of 65,000. Because let's see, this was, I think, the year before. So a lot, but alcohol still has 88,000 deaths a year attributed to alcohol use disorder. So that's still the top if you remove nicotine from the equation. Actually, cigarettes kill more people than either of these, but of the classic addictive substances, alcohol is still the worst total. Societal impact, fiscal. So between these two, it's close to $500 billion that are spent on treating the or actually this is just total societal impact. So some of that is medical costs, some of it is lost productivity, some of it is the costs associated with the legal system and the legal problems. That's a lot. $500 billion. That's close to our deficit. I think the last federal budget was $4 trillion, or $4 trillion and some change. So that's basically an eighth of our federal budget that's being chewed up by addictive disorders. I think you guys have probably had lots of training on this, but just a couple of interesting pieces of this. The cage is good for detecting higher levels of substance use, and it's definitely very good in the emergency room. However, in ambulatory care settings, the audit C, that's a nice 3-item screener, and that is a little more sensitive in the ambulatory care setting. There is, I mentioned the NM assist, that's NIDA modified assist. Assist that's a World Health Organization screening tool for all addictive substances, and they've got an online version which is kind of nice. I've got a link to it there. You can actually, apologies, you can barely see that. Looks like it got lost in the coloring there. So treatment, usually dependent on the severity of the condition, and some of the sequelae. Hazardous drinking and mild alcohol use disorders have been found to be very amenable to treatment in the primary care setting. You know, a lot of times just talking with folks frankly about drinking, not in a nagging, scolding way, but just in a kind of a matter of fact, hey, I'm concerned about your health way. You know, in one of the ways you can do that is, you know, discuss what are safe drinking levels, and, you know, kind of by inference, what is hazardous. And let's see, do I have no, so just kind of as a guide, 2 or more drinks per day, or 14 per week. Actually, for a week, 14 for males. More than that is considered hazardous drinking. More than 7 for females is likewise considered hazardous drinking. There's other other levels based on other time frames, but that's a pretty good one to remember. Some of the treatment options in primary care: brief intervention that makes use of motivational interviewing techniques, basically getting folks to recognize the discrepancy between their current behavior and what their health goals are. And that's a whole lecture in and of itself. There's something called the 12-step facilitation method, and this is something that's very easy to do. You know, 12-step programs, AA and NA, have been shown to be very effective for some people, not all, but for some people. And 12-step facilitation basically refers to the provider taking more of an active role in trying to get someone hooked up with a 12-step program. So maybe giving them a number of a coordinator, or actually you know, referring a person directly to the coordinator, who would then, you know, kind of shepherd that person to a meeting. You know, saying going to AA. I mean, that's good, but if you can do a little bit more to help them get there, that's even better. And that's something that you could have your clinic staff be part of. And then sometimes primary care can help with pharmacotherapies for alcohol use disorder, and of course, what we'll be talking a lot more about, opioid use disorder. Generally, more severe cases warrant referral to addiction specialist, or substance use disorder counselors, for more extensive evaluation and treatment, and possible referral to residential treatment. There are tools that you can use that basically determine the current severity and which treatment intensity level would be best for any given patient. That's using the ASAM criteria. So just a couple of take homes. You know, again, you know, the addictive disorders are, you know, they're create conditions so complete that it really damages, you know, health, relationships, productivity. It really wreaks havoc with people's lives. And as you guys all know, it's very, very frequent. But it is treatable if it's caught early enough. So let's see, and then I've got references and so forth. All right, so let me go to see if I can open it up to questions where, all right, let me see if we got what we got going on chat. Okay, let me I am going to transfer everyone into the panelist category. So those people who do have a mic should be able to ask a question. If not, if you have a question that you'd like to send through chat, feel free to do that. You know, this was a very, very basic presentation, you know, just kind of giving the conceptual framework for addictions, you know, in general. Subsequent presentations are going to be more specific to Suboxone treatment. Yeah, we'll be certainly in future presentations, we'll be talking a little bit more about the MAT project. Let me take a few minutes now and talk about it. So the MAT project is it's basically ultimately funded by SAMHSA. SAMHSA distributed grants to all states in the country, and that was as a result of the 21st Century Cures Act, which was signed into law 2 years ago to address the opioid epidemic. It freed up a little over $1 billion for expansion of MAT. And so the state of California received about $100 million for 2 years. That's about a little over 50 million per year. $100 million for the two, and they're doing kind of three main things with it. One is that they are trying to beef up the hub and spoke model, which is sometimes referred to as the Vermont model. Basically, it's a system in which you have methadone programs. Methadone clinics basically act as the hub, and then individual clinics are the spokes, and you kind of the hub then acts sort of as a you know, a technical consultant, and they're, you know, kind of in general, methadone is well, at least it's sometimes better for folks with very, very severe opioid use problems, although you can usually do a good job with buprenorphine. But so, and that's where, you know, a lot of the experts are at the opioid or at the methadone maintenance programs. So, so they're the hubs. The spokes are the individual clinics. That's the first part. The second part is trying to expand the Project Echo. Project Echo is a basically it's a system of getting technical assistance from mostly academic programs like UCLA, and in this case, out to rural and you know, other settings that may not have specialists there. You know, it involves discussion of clinical case conferences or discussion of clinical cases, and there's some didactics. So it's a learning collaborative is the category. And then the third category was the tribal MAT program, and that was actually uh, divided into 8 different grant projects. So I'll just kind of mention a couple of the general grant projects. So there's a total of, I think, 6 million dedicated to Indian country for the state refers to as tribal MAT program. So one of the things that one of the contracts is going to be to develop an MAT champions program. And basically, there are going to be 5 individuals hired by California Rural Indian Health Board and California Consortium of Urban Indian Health Clinics. And they will be people who will be distributing Narcan. They'll be trying to help programs to get hooked up with the local opioid coalitions. They'll try and provide some education. They'll be doing training on Narcan administration. They will be helping to increase the telemedicine infrastructure, so they will be probably buying equipment for folks. You know, a lot of programs have 1 or 2 cameras. Number one, a lot of them are old and they're located in the medical clinic, and some of the we like to give behavioral health departments the option of being able to be part of the treatment. Telemedicine expansion in terms of the infrastructure is going to be part of it. So that's the MAT Champions Project. We're also funding UCLA to do a specific Project Echo just for Indian country. So that's another project. And then there's the project that I'm administering, and that has 2 components to it. One of the components is technical assistance. I've subcontracted with Katie Bell. She is an addictions nurse, public health nurse, has been working with Suboxone programs really since before it was authorized back in 2001. She was working on some of the original original research programs. And so she's got a lot of experience in helping programs to develop their own MAT program in their clinic, and ways to integrate it into the primary care flow. And she's got a lot of policies and procedures, and templates and all kinds of tools. And she's available to go out to your facilities and provide some on-site technical assistance. The other major part of the MAT program project will be the direct service portion. So we will be able to provide direct service for MAT patients. So if you don't have your project up and running now, or you're not sure whether you want to have your own clinic, but you do have patients that you'd like to get treated, then we would be able to treat them by via telehealth. and that's going to require a little bit of coordination, but you know, we'll be doing certainly the clinical work. And then there's also another kind of related service, and that is treatment of co-occurring conditions. So if you actually, it's for programs that either have MAT program but have a lot of patients with co-occurring conditions, are not quite sure what to do with and want some consultation on that. Or if you know, if you don't have your own project but still have patients with co-occurring conditions, you know, we can see them by telehealth, and you know, we'll the particular telehealth model that we'll use will be both evaluative if you just want to consult, but we're also willing to actually follow patients longitudinally. Um, Originally, we're going to be providing 6 hours a month, but we just got funded to expand our program, so we'll probably be offering more than that to each program. So that's what we offer in a